in cases where you cannot find an ideal view, you can use the help of rotational angiography while positioning your stunting.
Okay.
So another thing, I mean, if you use IVUS regularly, so with IVUS you can locate ostium. That's what I do many times, because sometimes you spend a lot of contrast in just positioning stunt in ostiums. Sometimes you will take 5 to 10 views. So IVUS will minimize, your contrast usage, and it will maximize your, capability to locate ostium. So you can use IVUS to locate ostium, and in the same view you can deploy your stunt.
Thank you, sir. Thank you.
Yeah.
Generally, we look at 3 views: LAO-caudal, RAO-caudal, and AP-caudal.
Yeah, this is another case. A guy came with a non-QMI with a TROP positive and very rapidly progressing angina. So he used to walk for 4 to 5 kilometers before, but within a month, so he's not even able to do his regular activities. So that means it progressed from class 1 to class 3 within a short period. So now I'll show his RCA. I mean, this is yeah, Sridhar, you can comment on this RCA, this view.
It is a epicranial view.
Any lesion anywhere?
Looks as if there is a distal RCA. There is a mild blocking is there.
So otherwise nothing, right?
Yeah, doesn't look.
Yeah. So I'll now show the other view, the conventional RCA view.
Yeah.
Ostial.
I could see an ostial tight lesion.
It's a tight lesion in the ostium, which you are not able to see in the cranial view, right? But quite visible in a routine view. Okay. So this is one thing in this case. Yeah. Let me show you. Yeah. The important point in this case is LMCA. Sridhar, you can comment LMCA. Already there is a lesion. I'm not bothered about it. Just comment LMCA.
So obviously it is not engaged properly, but you can see some haziness.
Yes.
Contrast opacification is different at the ostium when compared to mid and distal LM. So I think I need few different views to profile ostium of LM.
Yeah. So in this case, not able to enter coronary, that is one sign of disease.
Right.
Second, there is a irregular opacification or discordance in opacification from distal to the lesion site or ostium site. That is another, thing, which really says there could be something. And see this view. You're not able to see anything.
Right.
Right?
Right.
Yeah. Let me show this view.
Yes.
Ostial tight lesion.
So as I told, when you have inferior takeoff LMCA, which is long, not short, then I think cranial views are better to understand the ostium diseases.
See, now can you see the difference? It is a very eccentric block. Unfortunately, I don't have the IVUS. See, the IVUS showed, it's like a very eccentric block. In one view, the diameter is like less than 1, sorry. In the other view, my maximum diameter is like around 4. So this is a very eccentric lesion, and this quite commonly happens at ostial LMCA. So ostial LMCA is one area where many times people miss lesions. And before ending, see, wherever you suspect ostial LMCA, I think we have to take a couple of views before ending your angiogram. One is, as Dr. Sridhar already explained, caudal views, cranial views, where it works, like, a long LMCA or downsloping LMCA in those situations. But don't end your angiogram without taking elevocranial, plain AP, and sometimes some modified AP caudal to eleocaudal views. So without that, you cannot define LMCA. And sometimes you will miss despite all these views. So in those cases, what to do? In osteal LMCA, see, I tried in many cases with IVUS, but again, IVUS poses a lot of problems in osteal LMCA because at ostium, see, the cuts which IVUS takes is very oblique. So you will most of the times miss osteal lesions even in IVUS. So IVUS is also not a good modality to define. So I felt, angiography is the first thing. And if it doesn't work, you can try FFR in these kind of lesions just to know whether there is a significant lesion or not, and subsequently, other treatment decisions. And there are many reports on osteal LMCA. So it looks like this, what exactly is now. But in this patient, there are symptoms. There are many case reports where angiograms look like this and patients were sent to bypass surgery, and angiogram done 5 years later after bypass surgery became normal. So what's the reason? So again, a catheter tip spasm is the most important thing, which you have to rule out in such cases. So yeah, these case reports plenty of case reports are there in JACC, which you can see. So osteal LMCA is a very tricky thing. Sometimes you can't make out a lesion. Sometimes you can see a lesion, but it may not be there once your catheter is out. So, and some few occasions where I find an osteal LMCA, but patient is not symptomatic, or patient investigations are not suggesting an LMCA lesion, in those cases, and it is recommended to do a CT angio to see how the ostium is. We have done in a couple of cases, and quite recently in one case where CT angio showed a normal ostium. There is no plaque at all. So that's what exactly happens. Please beware of osteal LMCA lesions before taking a revascularization decision. Particularly if it is a surgical decision, you have to confirm your lesion if you have any iota of doubt.
Particularly if entire coronary system is normal and there is only isolated osteal lesion.
Yes. Yeah, that is a typical situation where you have to do this.
Right.
Yeah, we did angioplasty to this guy. I mean, as you guys know, osteal LMCA stunting is equal to bypass surgery. I mean, most of the clinical trials showed osteal LMCA is like equal to CABG. There is no issue with osteal LMCA. Yeah, I'll show another view, Sridhar, of this patient. Yeah, this is another view. I think areocranial view.
Yes.
So which confirms, the problem, right?
Definitely,
So,
it looks significant.
I think, yeah. So this is one case. Yeah. Next. Yeah. So probably I can show our strategies case. One case of strategy. Oh, okay. Yeah, I think I'll show this case. So. Sorry. Yeah, I'll show complete all views, and then I'll ask. I mean, we'll discuss. This will be our last case today. One of you can give a running commentary of what you're seeing. Sridhar, you can give a running commentary.
So it's a epicaudal view. So there is a significant long segment lesion in LCX and OM, and LAD also there is a long segment lesion with a lot of calcium. So both are critical lesions.
Yes.
LM looks to be normal. There is also probably a complete total occlusion of RCA with retrograde filling. I think a straightforward
Okay.
case for CABG.
Yes. So I think left anatomy is pretty okay, probably for all of you, right?
Suggest mid RCA total cutoff.
Okay, so
Yes,
uh, yeah, I mean, this is the picture. So can I end my angiogram or you want me to do something else? Can I come out or would you like to see some? Say, for example, I completed angiogram and came out. Patient is saying, I don't want CABG, I want PCI at any cost. What is the information which is lacking here? See the length of the lesion. In a CTO, length of the lesion is the most important thing. See, if you can get that information, length of the lesion, so you should always, that is always better, in planning a procedure. If you don't get that information in angiogram, we'll tend to do CT angiogram for these patients. But before thinking of CT angio, you have to try adequately with your angiogram to make out. See, in this particular case, Sridhar, can you make out calcium
yes, there is
at
lot.
the CTO, right?
Yes, there is
So
lot of
this is an LAO view.
Yes.
Yeah. So what
Yes.
you have to do is, in the same view, take your catheter into left system
Right.
and you inject. So take your catheter into left system in the same view and inject and see. Yeah, before, I mean, what is your opinion? I mean, do you think it's a short lesion or long lesion? Then I'll show that.
Long lesions.
You felt a long lesion, right? So now you see it.
Yes, sir.
Still you feel long lesion? If you observe, there are two kinds of collaterals to RCA. One collateral is acute marginal or RV branch, which is filling mid RCA,
Right.
right? And see the other collateral which is filling distal RCA. Can you see?
Yes.
So now
Yes, sir.
what you have to do is you please concentrate on the movement of contrast at PDA. This is very, very important. See the movement of contrast in before PDA, that is in the distal RCA. Anyone is able to appreciate to and fro movement of contrast in distal RCA?
Yes, sir.
What is it? What is the meaning of that?
Probably it is like what's a competitive flow kind of.
Yes.
Yes. So that means there is one collateral which is coming and filling, your mid RCA, another collateral which is filling your distal RCA. So mid RCA to distal RCA is intact. There is no CTO there. There is no second CTO, and mid RCA to distal RCA is connected. See, this to and fro movement in a vessel indicates a connection. So this is a short segment total occlusion, right? And if it was the only lesion for the patient, it would have been a good CTO to do it, right? So now you can understand, this to and fro movement of contrast is most important in identifying which collateral is filling, the CTO artery And it is also important in identify. Sometimes you are not able to make out a graft. You are not able to see where the venous graft is located. Say, for example, there is an SVG to OM. You are not able to locate it. I think there is another case probably. I think if it is there, I'll show regarding this to and fro movement. Yeah, it's missing. Yeah, so you are not able to inject the SVG. So what you have to do is you observe your native vessel angiogram. You are able to see a to and fro movement in one OM. That means the graft is there. You have to search for it. If there is no to and fro movement, or if there is no contrast, what should I say, non-uniform opacification of OM, then you can say that graft is gone. So, or the OM to which the graft is occluded is a CTO. Right? So, this is how, I mean, by observing your native vessel angiogram, you can say whether the graft is there or not. If it is not there, is there any CTO in the grafted vessel? So all these conclusions can be made out. Based on that, you can use more and more contrast to explore. See, if there is no to and fro movement, you can stop exploring further also, provided you are sure it is not a total occlusion in that vessel. Hope you all understood my point. Sridhar.
Yes, sir.
I didn't get it properly.
See, there is a graft connected to OM.
Right.
Right? So you are injecting in epicaudal view.
Right.
Right? Into the native vessel. Native vessel. Right. Okay. So if the graft is intact, right? And there is an antegrade flow into your OM.
Right.
So what exactly happens is there is a competitive flow.
In the
graft gives a non-contrasted blood, and from here there is a contrasted blood. That competitive flow you have to observe.
Right.
Understand? So you will get a kind of competitive flow in the proximal OM.
Right.
If that is there, that says your graft is intact, you please explore further.
Right. True.
If that is not there, you can blindly say, that graft is occluded.
Right. That is true.
If it is a total occlusion of the graft, sometimes you may see the graft from below upward.
True.
Sometimes, not many times. Okay. Right. So this competitive flow you have to always observe in doing a graft angiography. Whenever you're not able to make out a graft, based on competitive flow, you decide whether you have to explore further or not. Otherwise, you will end up in giving a lot of contrast to the patient.
Excellent point. If there is a good competitive flow at that anastomotic site, it indicates that graft is intact. There is no further need for exploration.
Yes. So in the same way, what you are seeing here, how you can see this point, this case which I have shown. Basically, in this case, I suspected, serial CTOs for this patient because of that anatomy. So I suspected a serial CTOs. The moment I saw there is.
But here that antegrade flow is from that acute marginal collateral. Is it that what you want to say?
No. It's not just from acute marginal. There is another collateral from just RCA. If you see RCA injection, if it is only from acute marginal, you can see.
Can you show that?
Yeah, you can see now. Why it is not only complete marginal is you are not able to see the vessel completely. That means there is a blood coming without contrast into that area. You see now. Very faint flow.
Right.
Hope you are able to see it.
But I'm not able to sync that. So that much amount of faint flow may not cause competitive flow is what I feel.
Yeah, that's a problem with C. Here, Sridhar,
Yeah.
if you want to make this out, you need a dual injection. That is the importance of dual injection. If you give dual injection to this case, you can see the entire distal RCA because you are filling both from
Both
collateral
antegrade
as well as from RCA.
retrograde collaterals.
Understand? So,
Right.
dual injection is the best method angiographically to see the length of CTO. But see, in angiogram, you have only one puncture. It is very difficult to give a dual injection. You can use all these kinds of analysis to understand length of CTO. Right? So, but
Right.
I have not given a dual injection to make my point clear. But I have observed so many cases. So, this is how it looks. The moment you give a dual injection, you can see your entire distal RCA because now you are sending contrast to through both routes, your entire distal RCA will be visible.
So to summarize, if you have single isolated RCA total occlusions, so wherein sending the patient to CABG may be difficult, it always better to take a dual injection to know the length of the total occlusions. If it is short, there are always doctors like Sharath who can open it up.
No, but always, we won't like to take a second puncture during angiogram. Nobody would like to take a second puncture. But before ending your angiogram, please look through all these signs and come to a conclusion, right? Then close the case. Don't close the case just like that. Understand? Yeah. So in this case, say for example, your LAD is not deceased. I have another case, but I don't know how to. It's there in okay. In this case, LAD is normal, LCX is normal, right? So then you should not end angiogram without visualizing collaterals, right? So what you have to do is take arevocranial, plain arevo, and arevocaudal injections of left system, and better in 30 frames with a long injection, just to visualize collaterals. Because once you complete analysis to do a PCI. So if you don't do your arevocranial, arevo and arevocaudal views, so it's very difficult to define collateral circulation.
You will end up in doing one more angiogram.
Yes, that's what exactly happens. I keep saying my patients, with this angiogram, it is difficult for me to plan a procedure. I'll plan procedure while doing angiogram. I'll do angiogram and then I'll plan procedure in the same sitting. And sometimes I end up in second sitting because to make up mind for a CTO, it is very difficult. So, on table with an ad hoc basis. So CTO is not an ad hoc angioplasty. So yeah, so probably we would end our discussion. This is what art of angiography means. That is why we have chosen that topic heading. I hope we justified this topic today.
Sir, can we come up with one question?
Yeah.
Sir, what is the preferred diagnostic catheter of choice for SVGs to left and right system, sir, through femoral? And what is and how do you approach to locate the origin of the SVGs, sir?
Yes, it's a good question. See, for right-sided SVGs, I mean SVGs to right side, right? Most often JR works. Most often JR works. Okay?
Yes, sir.
If JR won't work, then you try MPA.
Okay, sir.
MPA catheter.
Yes, sir.
Right? I mean, so far I never had a problem in engaging venous graft to RCA with JR or MPA. I never looked for other catheter.
Okay, sir.
Right? And for left-sided grafts, for venous grafts, I think for Lima already we discussed extensively in Sridhar's presentation. For left-sided venous grafts, always after doing a native angio, see, most often you will go with femoral only in these cases.
Yes,
After completing your femoral native LMCA angiogram, that is native left system angiogram, you pull your JL back, you turn it bit anteriorly and try to engage.
sir.
If it doesn't happen, pull that catheter out, right? So again,
Sir.
try with MPA.
Okay, sir.
MPA catheter, and the view for left grafts is come to RAO view.
Okay, sir.
Left graft is exactly an anterior aspect of left sinus. So come to a RAO view, right? And you try to pull your catheter, tilt your catheter anteriorly.
Okay, sir.
That is your MPA, and pull it back slowly.
Okay, sir.
Right? So
Yes,
very often it hinges at some point. Wherever it hinges, that is the graft location.
Okay, sir.
So the best view for left grafts is RAO view, right? And just pull your catheter over anterior aspect of your aorta, and wherever it hinges, that is the side you just inject and see. Okay.
Yes, sir.
Yeah. So, but
RAO helps in tilting your catheter or facing your catheter anteriorly, where most of the grafts are placed.
Yes.
Right-sided grafts are placed just above the RCA, that is on the right side of the aorta. But whereas the left-sided grafts are placed in the order of LAD, diagonal, OMs, slowly upwards, mostly on the anterior side. So your catheter, coming to the RAO will help in facing the catheter anteriorly, so that you just lightly pull the catheter such that it just hinges into one of the vessel. Then come to proper views and take the injection. Then come back to RAO, then pull up. So you tend to slowly engage one by one all the catheter. This thing.
In the order of LAD, diagonal, and OM ones.
Yes, LAD, diagonal, OMs.
Yes.
Upwards. And most of the times, MPA may not help. Most of the times, ALs. Which particularly face anteriorly. When you just tilt it anteriorly, that is towards the aortic wall. So they will help you in engaging quickly.
Okay.
And if you want, you can take venous graft catheters also. They more or like similar to MPA.
The ALs are more traumatic. These venous catheters are less traumatic.
Okay.
Sometimes you tend to engage with even JR also. You may not need other catheters.
Yeah, left systems. Yes, left systems also. Wherein the graft is towards right.
Right.
It happens. No, I had one case where venous graft actually it is it's very posterior. I never imagined surgeon will give such a posterior anastomosis. I mean, if surgeon don't want a cardiologist to do angiogram in future, that's what they do. It's very tough. But even in posterior, MPA works. In that case, MPA helped me. So MPA worked for me.
Many times patients do come with come to present post CABG without any records. Actually, they are not aware of any grafts being placed. In such cases, I generally start with a pigtail injection. So I generally just take the pigtail injection that in a LAO view that will help you know whether the grafts are patent or not. Of course, CABG is a chance of choice, but I generally do a pigtail injection to know whether the grafts are present or not. And that also gives you an idea about where the grafts are placed. Then you can search it.
Where do we place the pigtail, sir?
We place the pigtail in aorta.
Sinus.
In the sinus.
Okay.
Yes.
Okay.
Sinus. There is nothing like specific sinus. You put it in the sinus and inject.
Take an injector shot, not with the
non-selective injection. Anyway.
Okay.
But it would be a wise choice, to go with a CT angiogram in those cases where you have no reports at all.
Exactly. Right.
Yes.
Take a CT angio before going into angiogram. That always helps you in minimizing your contrast and
Sir. And sir, what is the preferred guide catheter, sir? If
same.
same, yes, sir.
Yeah, there's no difference, right?
Yes. Thank you very much, sir.
Yeah. So if no questions, I think we'll end this session. Probably it's too late, 2.5 hours.
Thank you, sir.
So, okay.
It was very useful.
Thank you, sir.
Thank you once again. Nice presentation.
Thank you,
You
doctor.
really enlightened us